Thank you so much, Dr. Manu. Dr. SUVEN is going to now either present or discuss with us all about IFIS. We've got about 14 minutes. Would you rather just discuss or would you like to see his presentation?
You said finish by 55, so we got less than 10 minutes. We got just 8, 7. So,
Lights off, please.
we're talking of intraoperative MIOSIS and iris prolapse. I'm sorry. So I do have a financial interest in the BX. I'll try to steer away from the BX as much as I can, but small people, you can't keep BX away. So this is a cataract, hard cataract was operating, and they have the nucleus gone, and halfway through the people started coming down. A bit of intracameral adrenaline didn't really help much. Some bit of dilatation, but then again, the nucleus was touching the pupil margin, so there was prostaglandin release, and the pupil came down. So at this point, you need a device. So I did inject viscoelastic over the anterior capsular rim and decided to place a BX pupil expander. It works very easy over here because you can just tuck that flange. You can tuck that flange under the pupil margin, and then we have instant confirmation that the rexus margin has not been engaged in your notches, and you can advance it to the periphery, and you're sure. And once you've reached that pupil of 5.5, you're pretty good to go. So this is a video which has been going around from 2013, presented at ACS in 2013, and this is different grades of IFIS, some of which we didn't even know, and later on we kind of realized, and I dug them out from my archives. So this is a myopic, sorry for the video quality, this was taken from a VHS. So here the pupil keeps coming down on you, inflate the anterior chamber, the pupil gets, see that iris prolapsing over there, inject viscoelastic, and it kind of inflates again, and the pupil dilates. So that's very typically of a IFIS pupil, which will actually, it's elastic. Now if you, some people have a feeling that probably iris hooks work better than other pupil expanders in IFIS. That's not really the truth. If you will see the next case over here, this is again with, iris prolapsing through all ports, and I needed to be a little careful over there while taking out the device, IA cannula, but then went off pretty well. So this was harmless. Now look at the next case. I've used iris hooks. I could barely finish my capsular rexus, and my iris was totally frayed. So the device really doesn't matter. I'll come to that a little while later. So most important is when you have a situation like this, either you change your incision if you can, but if you can't, the best thing is this is going to engage your phaco tip. So best is to protect your phaco, iris with the side port instrument as every time you go in, and remember that your iris is also very patulous, so it's going to come and hit any instrument that you put in through the side port. In the interest of time, we'll just skip this. And so there is iris prolapsing. So what I wanted to show over here is it's not the device, it's the severity of the IFIS which matters. So we'll just move to the next. So this is a particular case where I was using, I mean, most of you would probably not use the device, even I won't probably, but except for what I saw when I was just coming back with my visco cannula, and there was a little flutter over there when I just came back. So I didn't like it, and given the situation that we are in, short eye, shallow anterior chamber, I did think it would be a IFIS case, and it did turn hypertensive. Hypertension is a risk factor for IFIS, and so even with the BX, you'll have iris prolapse. So it's not the device which causes, which actually can protect you from IFIS. There's no absolute safe way. So the problem is that if you have a pupil which has come down to half its size, your viewing area has come down to quarter actually. So, and that is a disaster. So if you would like to be safe, and we do try to predict the possible occurrence of IFIS by we seeing the pupil size in advance. Well, it doesn't really work. 7 mm or smaller, irrespective of use of alpha blockers, can cause IFIS. Some of us tend to believe it's a Western problem, not so. So this is a large study by Shilpa Goyal and co-workers, and it did say that the incidence of IFS was higher in India, and tamsulosin, alfuzosin, hypertension was an important risk factor. That's a long list of situations and drugs which can cause. So it's absolutely unpredictable, and we need to be prepared. And there's a list of complications. I'm sure we've all burnt our fingers. So a disciplined approach is required. Keep a stock of devices in your OR, and this rest is a routine. So let's skip that. What I would like you to probably remember at every point in time is that we've all burnt our fingers, and if it's your eye which is going under the knife, what would you like your surgeon to do? However skilled the surgeon is, would you like him to be safe or her to be safe and use a device, or take chances and use a skill alone? You could take a call on that. Fortunately, surgeons are reducing the threshold because of unpredictability of IFIS and exacting patient expectations and the unforgiving nature of premium technology. We are using more and more premium technology. Let's see this video by Deepak Magor. See the advantage. There are devices are good, but there are certain devices which will have advantages. The devices like Malugian ring or the eye ring, especially in intraop miosis, you really can't be sure whether you're engaging the capsular access margin or not, because from a top view you cannot see the sides where the pupil margin is getting engaged. So probably a device like BX, which is in a single plane and with the notches facing you, would serve your purpose better. Now, because the choice is yours, and it's not the hardness of the cat. So a choice of pupil expanders in intraop miosis for me would be iris hooks or a BHEX, because they give you a lot of control and you are less likely to engage the capsular access margin. These are tight situations when you're there. So this is a question which often I've been asked, is which would be the best device? Well, as far as I'm concerned, I would like to divide, as usual, IFIS into miosis and iris relapse. For the miosis part, iris hooks or pupil expanders work very well, any of them, because it provides a constant pupil size and good visibility, which is, I think, it's paramount. So if you forget the iris prolapse and you just see that the visibility that you have, you need that central part to see that cataract and operate it. So both these, all devices will serve the purpose. You have safe phaco. For the iris prolapse, honestly, no device actually works. Nothing is foolproof. The iris prolapse depends on the severity of the IFIS and the pathological damage to the stroma. So you may get away with one device and on one day, and the next day the same device will not work. It's just your luck that day and the severity of IFIS in that eye. So I would probably prefer a device which has a low vertical profile and can exit through a small side port, and iris hooks and the BX serve this purpose very well. So this is very thin. It's about 75 microns, as thin as a human hair, and as you can see over here, you can remove it through a side port, which none of the pupil expanders you can do. So when you have iris prolapsing through all your ports, you'd probably prefer a device like this. So the lessons learned from these videos over here is that there are a host of systemic conditions which can cause IFIS, and hypertension is an important risk factor. Remember that. Every alternate patient is a hypertensive patient. And IFIS can occur in pre-op pupils less than 7 millimeter or less, irrespective of alpha blocker. And tamsulosin is often prescribed to women. Remember that. UTI is common and they often prescribe. Iris hooks and pupil expander do not eliminate the risk of IFIS. They may reduce the intensity of iris fluttering and prolapse, but they do maintain a constant pupil size, which allows you safe phaco. So every eye is an IFIS candidate. Reduce your threshold for using a device and keep a stock in hand. I recommend you look up these articles that are there available online. Thank you very much for your attention.